Good evening, everyone, and a very warm welcome to all of you. Dr. Malaya Mishra, the Senior Consultant and Head of the Department at Yashoda Hospital, Sikandrabad Unit. On behalf of Yashoda Hospitals, SEMI and Anbai, it is my pleasure to welcome you to today's expert session on a topic that is very much increasingly relevant to our emergency department. The topic for today's discussion is approach to polydrug abusers in the emergency department. So, as all of you know, polysubstance abuses is no longer an occasional challenge. It has become a daily routinity in most of busy emergency departments. So many of the times, these patients often present with unpredictable physiology, overlapping with toxidromes and complex medical and social issues, and sometimes very little history to start with. So, as emergency physicians, our ability to rapidly assess, stabilize, and safely navigate these patients can truly make a difference between life and death. So, we are honored today to have distinguished panel of leaders in the emergency department. For our today's discussion, we have eminent speaker among us. He is Dr. Suhas Sagar. He is HOD and lead consultant, emergency department at Sports Hospital, Sarjapur Road, Bangalore. Dr. Suhas is well known for his clear, practical, and evidence-based teaching approach. We are privileged to have him for sharing his expertise on this challenging topic today. So, without further delay, let us begin today's session. Now, I would like to invite our esteemed speaker, Dr. Suhas Sagar, to take us through his presentations. Dr. Suhas, over to you.
Thank you, sir. Thank you, Malai, sir, for the wonderful introduction. And like you rightly mentioned, polysubstance abuse is not once in a while isolated incident anymore. This polysubstance abuse has increased significantly in India, especially over the last decade. And these polysubstances that are being used for this abuse often include alcohol, cannabis, opioid sedatives, or sometimes even over the counter drugs, which are easily and readily available. So, like you said correctly in your introduction, we have very less information most times when the patient presents to us regarding what they may have consumed. So, all of that acts as a challenge to us when we are trying to treat a patient. So, what I've done is I've put together a comprehensive approach which everybody can follow, which will make it easy to treat a patient with suspected polysubstance abuse because we have very less information and a lot of it is at stake. Before we go to the topic of polysubstance abuse, I want to clear the terms which are used regularly, but sometimes they are misused. Like the terms associated with polysubstance abuse are use, misuse, and abuse. I would like to explain these terms with the help of a cough syrup example. If supposedly a doctor prescribes a cough syrup to a patient, use would be taking the right dose for the right use. That means the patient is using a cough syrup only for cough and he is taking the right dose that is prescribed by the physician. Misuse would be taking a more than required dose for cough, whereas abuse would be deliberately taking more than required dose and also taking it for purposes other than cough, as an addiction or as a dependent substance. You would be using the cough syrup. That would be abuse. So, moving forward with these terms, the next three terms that are commonly used are tolerance, dependence, and addiction. As we all know, tolerance can act by two major biological events. One is pharmacokinetic and one is pharmacodynamic. In simple words, pharmacokinetic tolerance is when the drug is not reaching the brain's receptors. Whereas in pharmacodynamic, the receptors are damaged or lost, so they don't respond to the drug. In dependence, the defining factor wherein which dependence can be explained is when withdrawal occurs. That means the patient is on a drug for a long time. The moment he stops, there is withdrawal effect. So when somebody experiences a withdrawal, then it can be termed that they are dependent on that drug. And coming to addiction, addiction is mostly behavioral. Like I said, addiction is defined by behavior. The substance abuse will continue despite negative consequences. Most common being alcohol abuse or smoking. People do see advertisements wherein which smoking or alcohol can lead to cardiac abnormalities or heart attacks. But even then, despite knowing the negative consequences, they continue to do it because they are addicted to it. At this stage, it is very important to seek treatment to break this whole cycle. So, what can be the causes of this polypharmacy or polysubstance abuse in India? Most important factor is stress. What we see as something simple and passes off every day as a habit may be actually contributing to something very big. For example, India has a very large population of young people now who are working in IT sector or jobs that require you to be at work for long durations, and they are in probably AC rooms from morning to evening. The only time they take breaks out of stress is when they take breaks to have a smoke, or after a long day's work they go and have a lot of alcohol. So these things start as habits or out of peer pressure or family history of abuse, and they become into actual causes leading to polysubstance abuse later on. So when we have a patient that is presenting to ER with a suspected polysubstance abuse, in any case in emergency, as emergency physicians, we would approach the case by ABCDE approach, airway, breathing, circulation. Unless if the patient is in cardiac arrest, then we use the CAB approach. In cases of suspected polysubstance abuse, we have to use the RSI dead approach. It's a slightly different from the regular ABCD approach, but even in this RSI dead approach, ABCDE exists. So RSI dead meaning resuscitation, risk assessment, supportive care, investigations, decontamination, enhanced elimination, antidotes, and disposition. In this resuscitation, we still do the ABCDs. So under resuscitation, airway, breathing, circulation, the obvious thing is to secure the airway. If the patient has airway secretions or the patient is not breathing, you would go ahead and secure the airway. But one thing that you can do extra here to clear the airway secretions in case of opioid toxicity is give naloxone. But just because you have given naloxone, you should not take it lightly when it comes to the breathing part, because most of the antidotes we use have a very short half-life. So because of the short half-life of the antidotes we use, again the patient can go back to a secretions in the airway stage or a respiratory depression stage. So breathing has to be taken care as well, even if the airway is managed properly in the initial phases. And if you are suspecting poisoning or overdose with tricyclic antidepressants or salicylates, which majorly act by causing metabolic acidosis, you can hyperventilate the patient to balance the pH. When it comes to circulation, you can have all the possibilities of hypo or hypertension, brady, or tachycardia. Eventually, next you will have to detect and correct seizures, hypoglycemia, hypohyperthermia, which are easily correctable in the ED by using medications. Finally, it is very important to know and have the knowledge of some emergency antidotes like naloxone for opioids, dextrose for hypoglycemia, calcium gluconate in case of beta blocker toxicity, atropine, as we all know, in organophosphate toxicity, and flumazenil in benzodiazepine. But there is one very important point everybody should know in flumazenil toxicity, that is, flumazenil, when given in a benzodiazepine overdose, can itself trigger seizures or arrhythmias, because patients who are on chronic benzodiazepine use, they'll be dependent on benzodiazepine. And when we give flumazenil and reverse the effects of benzodiazepine, it can itself cause seizure. And as ER physicians, we would be again depending upon benzodiazepine to control the seizure acutely. But there is an ideal indication to use flumazenil. It can be used in isolated or accidental poisonings after definitely eliciting the history that the patient are not chronically using benzodiazepines. Once you have the patient and you have checked the vitals, based on whether the patient has bradycardia, tachycardia, hypotension, or hypertension, you can think of the following drugs or the uh, materials that is available online, which can cause a polypharmacy abuse or a overdose. For example, if the patient is presenting with bradycardia, you can remember with the mnemonic paste, which are propanolol, anticholinergic drugs, clonidine, ethanol, and digoxin. All of this can cause bradycardia when they have taken in overdose. Similarly, for tachycardia, you can remember with the mnemonic fast, as mentioned here. For hypotension, you can remember it with the word crash, where in which you can think that the patient is crashing or the patient is hypotensive. Mostly are all antihypertensive drugs or sedatives or heroin or other opioids. Similarly, for hypertension, you can remember it with the mnemonic CT scan, which are cocaine, thyroid supplements, caffeine, and anticholinergics and nicotine. Finally, risk assessment. Under risk assessment, it is a common notion that when the patient comes to the ED with some substance abuse, as ER physicians, as junior doctors, we do ask the patient what has he consumed. And usually when they mention something called as aluminum phosphide, we think it's critical. But risk assessment should not be done only by identifying the agent. Risk assessment should always be done by considering the agent, dose, time since ingestion, clinical features that the patient is experiencing right now, patient factors, and always consider non-toxicological diagnosis along with the toxicological diagnosis when you're making a final impression. And you would have heard of this dictum from many pediatricians that children are not small adults. But when it comes to toxicology, dosing of antidotes, mg per kgs, you can consider children as small adults while doing the initial resuscitation part. Then coming to supportive care under RRSI debt, this supportive care is very important and it's very common. If you have done ICU rotations or if you work in the ICU, you would know this mnemonic very, very, very well. It is fast hugs in bed. As explained here, it's easily available on the internet. You can go through this mnemonic, which is fast hugs in bed, which involves continuation of acute resuscitation. In acute resuscitation, we took care of airway, breathing, circulation, fluids, hypoglycemia correction, seizure correction. Along with all of that, with continuation of treatment, you can give some fluids, feeds, make sure the patient is adequately receiving analgesia, sedation whenever required, thromboprophylaxis if the patient is bedbound for a long time, simple things like ulcer prophylaxis, glucose control. All of these things make a major difference because taking care of this fast toxin bread prevents further complications like hypoxic brain injury, be it aspiration, pressure injuries, urine retention, or acute kidney injuries, or in most traumatic injuries secondary to delirium. All of this can be prevented if you are doing a proper checklist of fast hugs in bed. Coming to investigation, we start with the G's, that is GRBS, blood gas, and ECG. Usually, if the patient presents to the ED in an unconscious state, GRBS is usually checked in the beginning itself to correct hypoglycemia, which is an easily correctable factor and also can be used as a reversal agent. If not, if the patient is conscious oriented, has come with another type of poison, eventually when you come to investigations, you do the GRBS, blood gas, and ECG. Under blood gas, like I mentioned, in tricyclic antidepressants or salicylates, you are expecting metabolic acidosis. That is how these chemicals act in the body and cause the poisoning. So you can do the optimization of pH by using hyperventilation or other measures as required. Under ECG, in cases of SSRI poisonings, you check for QT interval and correct with whatever medication is required at that moment. Along with these regular things that we see on a day-to-day basis, we also check for serum ethanol levels, urine tox screen, serum paracetamol levels, and based on the consciousness level of the patient and the respiratory presentation of the patient, you can also go for a brain, thorax, and abdominal imaging. Once we have done this part, we move on to decontamination. Although if the patients are very, very stable at presentation, decontamination can be done much earlier than this stage. Decontamination can be broadly divided into three main parts: gastrointestinal, skin, and eyes. As you all know, gastrointestinal decontamination, we do it with terms of bowel wash or stomach wash, whatever is done, and skin decontamination with a body wash, and eye wash for eye decontamination. This is the main three types of decontamination that is practiced in the ED. But even before we do this decontamination, during transfer or the time taken by the patient to reach the hospital, already some amount of medicine or the drug would already be absorbed. For such absorbed medication, we do enhanced elimination. So we don't want the problem causing drug to be in the system for a long time. So we enhance the elimination of the drug by manipulating the pH. Like I already mentioned, manipulating pH actually works in salicylates or tricyclic antidepressants poisoning, hemodialysis, and activated charcoal. This is probably the most important slide in this whole talk because every time there is a patient with polypharmacy or some unknown poisoning, everybody always thinks whether charcoal has benefits, whether this patient requires a dialysis or not. So you can easily remember with the mnemonic I fails. In this mnemonic I fails, iron, pesticides, hydrocarbons, acid or alkali poisoning, lithium or solvents. In this I fails, charcoal has no benefits. Whereas the dialyzable drugs or toxins can be easily remembered with the mnemonic I stumbled, which is put up here and easily available in the internet. If the patient has come with the dialyzable toxins, definitely you can consider dialysis based on hemodynamics, blood gas picture, whether it is metabolic acidosis or the patient is already hyperkalemic or the trend of creat or based on the severity of the agent drug duration that is consumed. Next, finally, antidotes. It is very, very, very important to note that the antidotes is coming almost to the end, and the antidotes is not coming in the beginning. Because when it comes to poisoning, our mind first goes to antidotes, but that is not correct. Why? I will tell you. In most cases, we do not know what the patient has consumed. So you do not know whether you can give an antidote or not, or in some cases, even if you know what the patient has consumed, that particular poison or a drug may not have an antidote. So we usually do not waste time on antidote in the beginning unless it is very clear. And if it's an opioid and the patient has respiratory depression, you can go ahead with naloxone. Otherwise, we do not give importance to antidotes in the beginning importance is given to mainly ABC and resuscitation of the patient to prevent immediate mortality. And when it comes to antidote, again, giving a single dose of antidote is not enough. I would like to explain it with an example of OP poisoning. Suppose you have an organophosphate poisoning patient, you use an atropine. So 1 dose or 2 dose or 3 doses of atropine is not enough. The knowledge of how an antidote works, the method of administration, and what are the monitoring requirement. How do you monitor once you give atropine in a case of OP poisoning, and what are the therapeutic endpoints? As you would know, we call it atropinization. In organophosphate poisoning, we see for endpoints of atropinization after giving atropine, which are clear chest tone auscultation, heart rate of more than 90, BP stabilized, patient is having dry axillae now, pupils are no longer pinpoint. So these are the things we look at after giving atropine, which is most important because in most cases, a single dose may not have the adequate or a sustained response that you are looking for. Finally, disposition. You would have seen if you are working in a tertiary care hospital that most cases of poisoning are referred to you. They come from suburban areas where patients are easily having access to, organophosphates or insecticides, pesticides, or other poisoning. In the IT crowd or in the metro cities, you have poisonings with tablets, which are either SSRIs or benzodiazepines. So if you are working in a smaller center and you have to transport the care to a tertiary care center, a single dose of antidote is not enough. You should write down the antidote related information, what you have already given, and after giving that antidote, what is the response the antidote has elicited. Because during transfer, the response may come down, and after they receive the case in a tertiary care hospital, it will give them all the information required to decide whether there is another requirement for antidote or not. And obviously, there is multiple risks involved with transport. So Pearl's take-home message from this short topic is, are RSI dead? It is ABCD, definitely yes, but are RSI dead? The most important part in this are RSI dead would be resuscitation takes more important when compared to antidote administration, because antidote administration alone is not enough to prevent mortality and morbidity in polysubstance abuse cases. And as you have taken the vitals of the patient, once they have come into the emergency department, always remember fast-paced crash CT scan when you have bradytachy or hypotension or hypertension, which will help you somehow taper it down to the possible cause of polysubstance abuse or if it's a single substance abuse. Always be careful while using Flumazenil because benzodiazepine withdrawal can cause seizures. If you're using Flumazenil, always be sure that the patient has taken one isolated incident of overdose and they have not been on benzodiazepine for a long time. It's a single event. Supportive care is invaluable. In most cases, when we have a substance that the patient has consumed or the patient has taken in as an overdose, and for example, it's some random acid or alkali substance, and there is no antidote, we as ER physicians, we tend to think, oh, this does not have an antidote, so this case is going to have high mortality or morbidity. No, it is not true. Supportive care is highly invaluable, and when it comes to supportive care, it's not just giving fluids when the BP is low or controlling temperature. It is fast hugs in bed. Go through the mnemonic. Make sure you're checking it every now and then. And that has invaluable importance in preventing later complications like acute kidney injury or acute liver injury or any other thing that can happen. Always have the knowledge of dialyzable toxins and benefits and contraindications for charcoal on the back of your head. Like I told you, dialyzable toxins can be remembered by I stumbled, and the I fails mnemonic can be used, wherein which charcoal is not useful. And whenever you're giving an antidote, please remember it is not the end point of treatment, but when you're using an antidote, you should know what are all the endpoints that you should look for and when you should stop or how you can transport the patient after giving an antidote by documenting everything that is given to the patient. So I thank the Yashoda management for giving me this opportunity to touch upon a topic that is really important. I would love to take questions. Thank you very much for the opportunity.
Yeah, thank you, Dr. Suhas. It was a wonderful discussion. I think you have discussed, you have touched very relevant points as far as our emergency medicine is concerned. So here this session is open for discussions. Dr. Suhas, like I have a few questions for you. Like in your practice, what clinical features prompt you to suspect polysubstance use rather than a single agent toxicity?
Right, sir. So clinical cue actually most of the times it is the patient attender's word, sir. So usually these patients are unresponsive especially when polysubstance is involved. Very less chances that a patient takes multiple drugs and comes walking into the emergency. They're usually found unresponsive at home, and they would already have a psychiatric history or a stress history, and they would be prescribed SSRIs. In most cases, what I have noticed is these kind of patients, they are in follow up with multiple physicians as well, not just one psychiatrist. Probably one psychiatrist, one physician, and the psychiatrist would be treating for depression with SSRIs. The physician would be giving benzodiazepines for loss of sleep. So they have easy access to polypharmacies, and one day when they feel that they are under stress, they do take multiple medications which are prescribed to them actually by other people. Otherwise, the common substance which constitute to polysubstance use would be alcohol plus something. In such cases, when the patient becomes unresponsive, usually they are found with bottles or tablet bottles, which the attenders will give us an idea of when they come. In cases of this suburban population I was talking about, wherein which the farmers, which they use insecticides and pesticides, is usually a single substance abuse. Although it gives us a pattern, we can never be fully sure until we get the urine toxicology reports. That's exactly why we give importance to resuscitation and not antidotes in the beginning.
Exactly. Yes. And there will be many times there will be multi-system involvement. It could be
Right, sir.
cardiac, it could be CNS, it could be metabolic. So we need to work on a systematic approach to
Correct.
narrow down our diagnosis and should treat
Yeah.
accordingly.
Yes.
So one more questions I have for you, like how do you decide when to prioritize bedside glucose monitoring and ABG versus VBG and ECG is an unknown substance abuse?
Right, sir. So to answer that question, it's all based on patient presentation, basically. Even if two patients have taken the similar drug abuse or polysubstance they have taken, they can have different presentations based on their age, the time they have taken, the kind of bioavailability of the drug, how long they have been on the drug, whether they're already resistant to it. So ECG monitoring for males and females, we check for the QT prolongation based on the higher limit of normal. If they have a borderline QT, we do repeat it every 2 hours, and we keep them on continuous ECG monitoring based on monitoring leads. And hypoglycemia, if the initial presentation itself is hypoglycemia, which is done by GRBS, once we correct, we check immediately, and we always check hourly whenever it is required. So once it is stabilized, then we go for a 4 hour or 6 hour when the patient is able to eat orally. Until the patient is able to not eat orally or they're unconscious or on a ventilator, we do it hourly and as and when required after that based on the sugar level stabilizing. And to answer your question regarding
ABG or BBG?
BBG or ABG, oh, that is based on respiratory involvement. So if the patient is too critical and an initial dose of antidote has not cleared air when we are going to intubate him, we will not spend time doing an ABG. We'll get a venous access, draw the VBG, and then use the drugs that is required to intubate the patient. If they continue to have respiratory involvement, we do an ABG. But in cases of poisonings, it is not shown to have major difference if you're doing an ABG or VBG, unless it is like a patient with a prior COPD or history, and we have some data. In usual poisoning cases, we do not get that much information. So studies show there is no major difference whether we do an ABG or a VBG in an acute presentation of a poisoning case.
Yeah, as correctly mentioned, it is true. So
Yes.
wonderfully explained about this needing of like ABG, BBG versus these cases. So I have another questions for you. Like when would you consider administering naloxones empirically in an unresponsive patients with unclear ingestion history?
Okay, sir. As you would know, the recent update of ACLS 2025 under airway, it says naloxone can be administered if the patient is unresponsive. If the patient is clearly unresponsive, it can be considered like we have a dictum in emergency. Every chest pain is MI unless proven otherwise. So every case of unresponsiveness, we can give naloxone even if we do not have the history. In fact, some European guidelines say if you have an unresponsive patient and you're suspecting a drug abuse, you can go for a 25% dextrose, you can go for an naloxone even without checking sugars or confirming what type of overdose they have taken, and which is also reflecting in the ACLS guidelines now. Naloxone can be given to unresponsive patient. Prophylactically, definitely we do not give, because if the presentation is completely unresponsive, it can be given even without thinking. If the patient is borderline responsive or opioid toxicity, we give. If the patient is walking, talking, conscious oriented, we usually do not give as a clinical practice.
Okay, very good. Wonderfully explained. Like which investigations are must do for all suspected polysubstances cases in an emergency room,
Right,
and
sir.
what are
As
the
we
optional based on clinical judgment?
Correct, sir. So this, as I mentioned, we would start with the Gs, that is the GRBS, ECG, and VBG. Not because they are only important, it's because whatever the findings we get on GRBS, ECG, and VBG, they are easily correctable as well. So if we get a hypoglycemia, it's straightforward. You have an unresponsive patient due to hypoglycemia, straightforward, you can get them back to normal, can prevent a possible intubation or a longer stay in the ICU course. Similar with ECG, if they have a QT prolongation, prolonged QTs can cause arrhythmia, because of which they are unresponsive. Again, correcting it would get them back to normal. And the same thing with VBG. VBG TCA, that is tricyclic antidepressant poisoning, becoming very common, and it causes severe metabolic acidosis. That is how it presents itself. So VBG showing us that pH and our base excess, bicarbs, and all those things. Correcting that would again reverse the initial critical presentation. These are mandatory. Optional would be based on the presentation. If they have presented with a very coarse, bronchi or Krebs chest, you are suspecting an aspiration, or the initial CT or chest X-ray is bad, you want to get a CT done later on, or in most cases they have fallen down, hit their head, you don't know whether they're having an internal bleed or any other fracture that you're suspecting, because in most cases they tend to have falls or seizures. That cases we can add off, head and abdominal imaging as required. But ECG, VBG, and GRBS, along with the initial bedside investigation as and when required for the patient, is very important. Point of care testings has high importance. Additional CT imaging would be case specific based on the system that we are suspecting, usually which are secondary injuries. Unless it is acid and alkali burns, we would need it immediately first up.
Yeah, and in addition to that, I would have to highlight few here. One is like lactate values, but definitely that will
Right.
plays a great
Right.
role. And creatinine kinase, particularly in case of rhabdomyolysis,
Abdomyolysis
suspecting,
suspect.
we can do that. And serum levels of, serum acetaminophen levels, serum salicylates levels.
Salicylate levels, paracetamol
And
levels, yeah.
yes, and urine
Ethanol
tox
levels.
screen is not routinely recommended because the reports will come after 2 days or three
After
days by
two
the
days.
time the patient
Yeah.
will be discharged, and
Correct, correct.
there will be not much having any clinical significance.
But
And
in
many of
acute care,
times,
definitely, sorry,
yeah,
sir, in acute care, definitely we do not have clinical significance of urine toxicology. But
yes,
when we are talking about polypharmacy abuse, definitely,
yes,
because
that
couple
there
of
is a
days
thing.
later, we need to correct something that we have not considered, definitely it will help. But not in acute care, like you mentioned, as ER physicians, not much of a use for us, yes.
So one last questions for you, like it's ethical and legal considerations point of view. So how
Right,
do
sir.
you document capacity assessment in intoxicated patients who refuses our care, primary care they refuses? So how
Mm.
would you like document this thing?
This will always remain a challenge, sir. As ER physicians, we are not capable, or we are not well versed with capacity assessment as well. Ideal would be to involve a psychiatrist where they can do a quick assessment. But as ER physicians, we have two extremes when making a decision. If the patient has presented to us in a severely critical condition and they're unresponsive, the diagnosis and the treatment is quite easy. Consent does not even play a role because it becomes life saving treatment. If the patient has come in a very conscious and a stable way, it also gives us time to take these things into considerations. So if the stable conscious patient has come himself to the hospital seeking treatment, again it becomes easy. If he's forcefully gotten into the hospital, attenders want treatment and he doesn't want treatment, that is where the question you asked has importance, where we have to think multiple times, especially if the patient is an adult and he has decision making capacity. Definitely forever this will be a problem for us emergency physicians. But luckily in Indian scenario, somehow the attenders convince the patient. In a US scenario, how much ever the attenders convince him, the patient claims that he is an adult and he has only right to make a decision. So luckily that is a good thing for us. But again, I don't think as ER physicians we have the capacity to make that decision. But it is made easy for us by the attenders or the patient himself. But ideally, theoretically, medico-legally speaking, it has to be done by a psychiatrist, at least over the phone, who is asking us questions and documenting it and going through a checklist of events, which gives us whether he is mentally sound to make that decision capacity or not.
Yeah, like all patients, poison patients presented to our emergency room should have a psychiatric counseling
Right, sir.
before disposing the patient to
Correct.
room or whatever the places they are staying. We should make a
Yeah.
mandate that all patients coming to our emergency room, poison patients, they should have a psychiatric follow-up, or else
Very
they will
important.
commit this crime next time in a very huge manner.
Correct, sir. Correct.
Okay,
Yes, sir.
so thank you. If any more questions are there, we could put up and we could ask Dr. Suhas to answer all those. So to all our participants joining from across the country, and thank you for making this time for this Friday evening, and your enthusiasm and commitment to learning are what we make these sessions are meaningful. So we hope today's sessions gave us a structured, practical, and ED focused framework for managing these complex police substances abuses cases, along with these valuable take home points as we are discussing. So thank you, everyone. Thank you, Yashoda management people, for giving us the opportunity to share our thoughts and discuss about this very much relevant topic in day-to-day practice. Thank you, everyone. Thank you,
Thank
Dr.
you.
Sree.
Thank you so much
Thank
for
you.
your time.